I'll now introduce our next speaker for the afternoon. Courtney will be joining us from the Cook County Department of Public Health. And just give us 1 second as we queue up Courtney's camera and presentation. Okay, so just the presentation. Courtney, are you on?
Yeah, can you hear me?
We can. Thank you so much.
Okay,
take it away.
Perfect. Hi, everybody. My name is Courtney Canane. I am the Applied Epidemiology Fellow at the Cook County Department of Public Health Communicable Diseases Unit. And I'm going to be presenting on mapping multi-drug-resistant organisms in suburban Cook County and how we are using GIS to strengthen our infection control response. So just a little overview of what I'm talking about today. I'm going to first give some context on what MDROs are exactly and why they matter, and then just talk about them on a national level, and then we'll dive into the suburban Cook County context, talk about our public health response and how exactly we're using GIS. So first, what are MDROs? So MDRO stands for multi-drug-resistant organisms. So basically, these are organisms that have developed a resistance to several different types of antibiotics. So the medicines that we typically take to kill them and to stop an infection are no longer effective, meaning that infections can last a lot longer and be more severe and potentially lead to other complications. So these are just some examples of MDROs that you may have heard of, may not have heard of, but are just more common. Today, I'm going to be talking about generally just MDROs in general. I'm going to focus on Candida auris, or I may refer to it as C. auris later. But so just how do these organisms actually become resistant to antibiotics? There's a couple of different ways, mostly through mutation. So that looks like bacteria randomly changing their genetic material. So basically, if one of those random changes helps an organism to survive against an antibiotic, then that mutated bacteria will live while others will die, and therefore it'll be passed on to future generations of that bacteria. Another way is through the misuse of antibiotics. So resistance can be made worse when antibiotics are used incorrectly or too often. For example, that can look like taking them when they're not needed, like for a viral infection, not finishing your full prescription, or maybe using leftover antibiotics from an old infection that you had. So this can be kind of difficult to just hear from me. So this is just a video. Let me know if you can hear it, but talking about this mutations more in depth. So
as a nurse, you give 100%. At Post University, our 100% online nursing programs are 100% on your schedule. Apply now to go from RN to BSN in as little as 12 months. Learn more at post.edu.
So what we ended up building was basically a petri dish, except that it's 2 feet by 4 feet. And the way we set it up is that there are 9 bands, and at the base of each of these bands, we put a normal petri dish thick agar with different amounts of antibiotic. On the outside, there's no antibiotic. Just in from that, there's barely more than the E. coli can survive. Inside of that, there's 10 times as much, 100 times, and then finally the middle band has 1,000 times as much antibiotic. And then across the top of it, pour some thin agar that bacteria can move around in. The background is black because there's ink in it, and the bacteria appear as white. First, you see they spread in the area where there's no antibiotic, up until the point they can no longer survive. Then a mutant appears on the right. It's resistant to the antibiotic, it spreads, until it starts to compete with other mutants around it. When these mutants hit the next boundary, they too have to pause and develop new mutations to make it into 10 times as much antibiotic. And then you see the different mutants repeat this at 100. And after about 11 days, they finally make it into 1,000 times as much antibiotic as the wild type can survive. And so we can see by this process of accumulating successive mutations that bacteria, which are normally sensitive to an antibiotic, can evolve resistance to extremely high concentrations in a short period of time.
hopefully you heard that. But I hope that gave a better description of how these bacteria are actually mutating. So just now talking about, now that we know what they are, I'm going to go into why these actually matter and how these are affecting us. So US estimates in 2019 were that antibiotic-resistant bacteria and fungi cause almost 3 million infections and nearly 36,000 deaths. So obviously this is a big problem, but it's also a very rapidly increasing problem. So this is a graph from CDC depicting national clinical cases of C. auris over time. As we can see in 2016, this wasn't really an issue, and now this is a very rapidly evolving issue, and these numbers are continuing to increase. So a similar increase is being seen in Cook County and Illinois. So just in general, C. auris was identified globally in 2009 in Japan. And Cook County identified its first case in 2016. And this case was only the 5th one in the US. And then from 2016 to 2024, there have been nearly 5,700 C. auris cases reported in Illinois. And obviously due to population, most of those were in Cook County. So why does this matter? Clearly, this is a big problem, and there is not much media attention or just public knowledge of MDRs in general. I'm sure you've all seen news and stories about other public health topics like COVID, flu, measles, but maybe not necessarily the MDR outbreaks that are happening right in our backyards. This is especially concerning because though you may personally not be at a huge risk of contracting an infection from an MDRO, our most vulnerable populations typically are the ones that are most impacted. So these outbreaks and infections typically occur in long-term care facilities or other healthcare facilities where older adults and others with weakened immune systems may be staying for long periods of time. So even if it seems like something that you may not be directly impacted by, I'm sure someone you know personally might be in a long-term care facility or might have stay there in the future might be impacted by this. So talking about those facilities more in detail, Suburban Cook County has a very dense network of long-term care facilities and other types of facilities like skilled nursing or acute care hospitals. We have 236 total, and that is a high number in general, but also by looking at data, we have seen that there are a large number of patient transfers between these facilities. So let's say, for instance, an elderly individual that resides in a nursing home might contract an infection and be taken to an acute care hospital. And then they might require a higher level of care and go to a skilled nursing facility or some other type of rehab center. So that could be transfers to 3 different facilities in a short amount of time. And if screening isn't adequate for MDROs, then that can result in a really high risk of transmission. So this is just a map outlining those facilities. Obviously the dots represent a facility, and it's broken down by different type. We've got acute care hospitals, long-term care, psychiatric hospitals, just a lot on here. And just for some context of the Cook County Department of Health's jurisdiction, so we cover Suburban Cook. So that is Cook County minus Chicago and a few other municipalities that have their own health department. So honestly, the dots pretty much outline our whole jurisdiction there. And so now talking about our public health response and what we're doing for this. So the Communicable Disease Unit at the Health Department has expanded our infection control infrastructure and have hired dedicated infection control epidemiologists. So these epidemiologists work directly with our long-term and acute care facilities in our jurisdictions to build strong relationships with the infection preventionists that are on staff at those facilities. And just some work that they do to target MDROs. First are point prevalence surveys. And these are essentially like snapshots of MDROs in a facility at a given point in time. So during these surveys, residents are screened for infection or colonization of MDROs. And we also just collect data on facility practices and just other potential risk factors in that facility. These epidemiologists are also conducting ICARs. which are structured evaluations designed to help these facilities improve their infection prevention practices. So during these evaluations, those epidemiologists review policies, observe their day-to-day practices, and just interview the staff to talk about any strengths or gaps in infection prevention that could be addressed. This can target things like hand hygiene and cleaning, all the way to their outbreak preparedness and their plans. So probably most importantly in general is just our relationships with other local health departments, the Illinois Department of Public Health, and mostly these facilities in general. Working with MDROs requires all of these different organizations to work collectively together, and having those strong relationships makes this work a lot more effective and just efficient in general. So now how we're actually using GIS. So we are in the middle of creating an internal dashboard for our health department staff, specifically those working in our informatics and those infection prevention epidemiologists, to track MDR activity across our jurisdiction in Suburban Cook County. So this dashboard will be bringing together all of our surveillance data that we get, and just general information on the facilities, like how many beds they have, stuff like that, into one single interactive map. And so our EPIs will be able to look at this map and filter by organism, time period, or just the facility type. And the system will automatically highlight our high burden facilities with a visual alert. And this is really significant for us because typical work in epidemiology, we get a lot of just spreadsheets with hundreds to thousands of lines of data. And looking at these spreadsheets and attempting to quickly spot any emerging outbreaks or clusters at a specific facility, it can be really time consuming and requires the use of a coding software. And just overall not very efficient. So with this map and this dashboard, our epidemiologists will be able to quickly spot a facility that might be having a larger than normal amount of cases, and immediately know to reach out to that facility and see what might be going on, and see if they needed any help from the health department. So having this as a resource is going to make our work a lot more efficient and effective, and hopefully really speed up our infection control response. Where we're at with the dashboard right now, we're still in the early stages of development. Right now, we're working on data cleaning. It can be pretty difficult because we're getting a lot of data from a lot of different sources. A lot of different types of reporting happens. So right now, we're cleaning the data, making sure that we are appropriately deduplicating and making sure that each facility has the correct number of case counts. So once that data is cleaned, we'll be using how typically our health department dashboards are using our Shiny to create this. So yeah, we're still in the pretty early stages of data cleaning, but we're pretty optimistic about where the direction that we're headed. So just some closing thoughts. Hopefully you've all gained a better understanding of MDROs and actually might know what they are now, and the burden that they're placing not only on the health department, but also on these facilities in our jurisdiction, and just how we at the health department are using GIS to make our public health response better and faster and more equitable. Okay, that's all I got.